Our next section is Parkinson's disease. Now, Parkinson's disease is a movement disorder. Parkinson's disease is a gait disorder. Parkinson's disease gives you abnormalities of movement, of walking. Everything is slow. I do not have enough dopamine in my substantia nigra. So my everything becomes slow. I'm trying to walk. Slow, slow, slow. That's a very funny joke you just said. Ha 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 ha. I'm gonna run now. Ready? 3, 2, 1, bang! Ooh. Carving, hypomimia, pill rolling. Ready? Look at the tremor. Ready? Okay, I'm okay, I'm reaching, I'm okay, I'm reaching. Tremor at rest. Reach okay, tremor at rest. Hypomimia, cogwheeling. Everything small. So the most important thing is the diagnostic test of Parkinson's disease. Well, that's the test. The test is that you have no diagnostic test. Oh my God, it's so small. Micrographia, hypomimia, resting tremor, festinating gait. Then you go in and boom. This brings out all of the sadism of neurologists. Every sadistic neurologist for the last 300 years sticks a needle in a guy with Parkinson's and see, it doesn't bother him that much. Look at his face. See, it doesn't hurt him that much. Look, he's barely having a facial expression. You get micrographia, hypomimia, cogwheeling rigidity. You get orthostatic. Because when you go from a lying position to a standing position, you have a tachycardia, a constriction of your blood vessels. A tachycardia and a constriction of your blood vessels that allows your blood pressure to come up. But what happens if you have autonomic instability? If you have autonomic instability, then when you go from a lying position to a standing position, instead of tachycardia, what happens is that you simply don't get a heart moving fast. You don't have the blood vessel constricting. The same hypomimia, micrographia, cogwheeling rigidity, festinating gait is happening in your autonomic nervous system as well. And that provides you an orthostasis from going lying to standing. Now, that also, first slide, that's where you see here Shy-Drager syndrome. When you have Parkinson's, and the most important thing is the orthostasis, that is called Shy-Drager. Now, progressive supranuclear palsy, well, what is this? I know it's above the nuclear, but nuclear what? Cranial nerve nuclei. Vertical gaze palsy is because it's the cranial nerve nuclei. So the ability to lift up the eye, cranial nerve 3, lift up the eye, has been damaged. So progressive supranuclear palsy means damage to the cranial nerves and you can't look up. Supra palsy, supranuclear palsy. Supra palsy, look down. Can't look up. Can't do supra, I do low. Can't do supra, I do low. Now, look at this word here on this slide. Olivopontocerebellar. Let me think about this. Ready? Olivopontocerebellar. I make it a habit never to learn any word that has more than 6 syllables. So I can't learn this. So we got to take this word olivoponto and just say the word cerebellar. So just think of olivoponto and forget the olives, forget the pontos, and get me the cerebellar, and now you see it's Parkinson's and ataxia. Now you know why. It's just Parkinson's and ataxia. Parkinson's disease and ataxia. Olivoponto. Cerebellar! ataxia. Cerebellar ataxia. Next slide. Now, the issue with Parkinson's disease is that when the dopaminergic qualities go down because the substantia nigra has been destroyed, the cholinergic qualities go up. And if you have too little dopamine and too much acetylcholine, what ends up happening is you get Parkinson's disease. Okay, let me be very straightforward here on Parkinson's disease. There is no diagnostic test for Parkinson's disease. There's no blood test, there's no scan. It's very unusual for neurology. Neurology is basically a diagnostic art, at least at large for a long time. So there is no diagnostic test here. Hypomimia, micrographia, resting tremor, autonomic instability, micrographia, that's the diagnostic test. The questions about Parkinson's disease are all about therapeutics. And here's how the Parkinson's disease questions are going to go. The Parkinson's disease questions will go like this. You ready? This is going to seem complex because a lot of these drugs don't get used for anything else except Parkinson's disease. The other thing is that some of you may get upset because you want to have one clear answer. Here's Parkinson's, use this drug first. It doesn't work like that. Let's look at some of the treatments here, okay? Okay, you look at this thing and you say carbidopa, levodopa, pramipexole, pergolide, ropinirole, COMT inhibitors. Oh no. Let's see, that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 separate medications. What are you supposed to do with that? What's the answer? Oh my God, that's more possible choices than the A, B, C, D, E. You need 2 questions just to get all the choices. So it goes like this. You see, if you are less than 60 and you have mild functional impairment, you're going to use an anticholinergic like benztropine. You're going to use an anticholinergic like benztropine if you are under 60 and have mild functional impairment. Now, above the age of 60, we don't like to use anticholinergics because anticholinergics, if acetylcholine makes you salivate and lacrimate and urinate and defecate, salivate and lacrimate and urinate and defecate, anticholinergic makes you have urinary retention. Anticholinergic makes you have constipation. Anticholinergic causes problems. So if you're above the age of 60 and you have anticholinergic problems, we use amantadine instead. Now amantadine, no one's quite sure why amantadine works. Amantadine works, we think, by squeezing out a little increase in acetylcholine. So amantadine is used when people are too old for anticholinergics. Anticholinergics have adverse effects. Now, you may think they're mild because they're not your adverse effects. But how'd you like to go through life going like this all day long? Dry mouth. Dry salivary glands. You know, you make 1 to 2 liters a day of saliva. I bet you didn't know you were so juicy, did you? Do you know that you're supposed to make 1 to 2 liters a day of saliva? That 1 to 2 liters a day of saliva is supposed to blow the dirt and the food off of your teeth. Keep it clean. No saliva, dry mouth. No saliva, you can't taste your food. No saliva, you feel very uncomfortable. No saliva is a drag, man. So it may seem like a minor thing to you because it's not your ability to have dry mouth the rest of your life. So if you're over the age of 60 and you're vulnerable to the anticholinergic effects, we use amantadine, which has less effects on the anticholinergic system. Now, mild disease, there's no objective measure of mild. You simply ask the patient, can you take care of yourself? What do you mean by take care of myself? Like emotionally? No. Can you cook? Can you clean? Can you dress? Can you shop? Can you pay your bills? What if you're too weak to get out of bed? What if you're too orthostatic to get out of bed? What if you're too slow to make it across the street? You have to be able to get down the street. Can you take care of yourself? Are you able to do the activities of daily living? If you are, then you have mild impairment. Amantadine, anticholinergics. Well, if you have more severe impairment, if this is more severe, then if you have more severe impairment and people really are having a crappy life, then we have 2 choices. Now remember, we have the handy Dr. Fisher way to be able to get all these Parkinsonian drugs organized. Just remember the good news. You don't have any complex testing? There is no complex testing. The second thing is, I don't even think they'll ask you the question, which of the following is the most likely diagnosis? Because the hypomimia, mask facies, resting tremor is so obvious to most people that 95% of people get that question right. Your question on Parkinson's disease is for you to know there's no diagnostic testing and everything is about therapeutics. So if you have more severe disease, if you have more severe disease, severe disease, then you have two choices. Unquestionably, levodopa combined with carbidopa. Levodopa combined with carbidopa is the most powerful of all the therapies. Levodopa and carbidopa is the most powerful of all the therapies because you're directly replacing dopamine into the system. You're directly replacing dopamine into the system. You're directly replacing dopamine. You're replacing L-dopa, and you're using a peripheral decarboxylase inhibitor, carbidopa, so that it doesn't become active in the peripheral system. We don't want it to become active in the peripheral system because too much dopamine in the peripheral system makes you sick, gives you nausea, diarrhea, and abdominal pains, a drag. We want the levodopa to pass into the brain, be converted to dopamine there. Now, the good news is that this is the strongest therapy. The bad news is it also has adverse effects. Something called on-off phenomena, which, as the name implies, means that sometimes what happens when you use this drug is that sometimes it runs out a little, sometimes it's too much, sometimes it's too little. It's not a nice, smooth, even level of dopamine. And people can get something where they run out or they have too much, they get adverse effects. So remember, amantadine caused an increase in dopamine release from the substantia nigra. So that increased dopamine release caused the benefit to the Parkinson's disease. This is replacing the dopamine. Now, the other alternative is I can squeeze out a little extra dopamine from the substantia nigra. I can replace the dopamine, or plan B, I can directly stimulate the dopamine receptors. Ropinirole directly stimulates the dopamine receptors. Ropinirole and pramipexole. Now, pramipexole and ropinirole are direct dopamine receptor stimulators. These are direct dopamine receptor stimulators. Now, the older drugs are bromocriptine, cabergoline, pergolide. Bromocriptine, cabergoline, and pergolide. Now, the problem with bromocriptine and pergolide is that they have more adverse effects and they also cause constriction of other blood vessels. But bromocriptine was the direct dopamine agonist. Now there are more gentler, less adverse effect ones called ropinirole and pramipexole. Let's give you what's good and what's bad about these. What's good about these is that these have less adverse effects, less of the on-off phenomena, So there has to be something wrong with them, or why would we be using L-dopa at all? If they have less adverse effects, then why do we use Sinemet in anybody? This is Sinemet. Why use Sinemet in anybody? L-dopa, peripheral dopamine decarboxylase inhibitor. Why use this in anybody? Because these has less potency. Like most things that have less adverse effects, it is less potent, less potency. Okay? So therefore, the direct dopamine agonists have less adverse effects, but less potency. So you could try them at first, and the good news is they won't make you sick as much. The bad news is they're unlikely to control your disease as much. Now, what happens if you give dopamine and you still can't get control? What happens if you give dopamine and you still can't get control? The last step of this is that you can add one of two agents. You can use the capones, the COMT inhibitors. The last thing is always get out the capones. Tolcapone, entacapone. Break out the capones dead last. Now, COMT inhibitors, catecholamine O-methyltransferase. What this does, in a short way for COMT, catecholamine O-methyltransferase, oh, shoot me now. Basically, what this enzyme does is this enzyme breaks down dopamine. This enzyme breaks down dopamine. So if I give you dopamine here and it doesn't work, these drugs will block the degradation of the dopamine. Here I replace dopamine, and the COMT inhibitors block the degradation of the dopamine. Well, so what happens is that this replaces it, and this decreases its metabolism. These drugs cannot be used alone because they have to be used with someone who's getting dopamine. Now, the hardest of the drugs to keep straight in your head is the other drug where you could add selegiline. Selegiline, an MAO inhibitor, is also another drug to increase dopamine levels. We used to think that this was neuroprotective. It's probably not neuroprotective anymore, and selegiline is used in order to be adjunctive. And therefore, this is the only one that it's hard to say precisely when to use it, because it can be used before these other drugs, after these other drugs. It's an adjunctive therapy that might work in some people in order to decrease symptoms. It was thought to be neuroprotective. It decreases the degradation of dopamine, and it also decreases the rate of progression of symptoms, we think. At least it ameliorates it. The major questions in Parkinson's disease is going to be, what is the treatment? If you have mild disease, you're still able to take care of yourself, then what you should do is you should give people, if they're young, an anticholinergic. Older people can't tolerate the anticholinergic symptoms, so therefore we use amantadine to squeeze out dopamine from the substantia nigra. Severe symptoms, we replace dopamine. The other alternative is directly stimulate the dopamine receptor. Less adverse effects, less potency. If adding the dopamine does not control your disease, we can add a COMT inhibitor to block the metabolism and also smooth out those on-off phenomena. Selegiline is an MAO inhibitor that also increases the dopamine levels and can be used adjunctively to these other drugs. The other points of this is, look at this next slide. Anticholinergic if your functional status is intact. Remember, functional status means I can still shop, cook, clean. Over 60, start amantadine. Compromised means severe disease. Levodopa, carbidopa. Levodopa is dopamine. Carbidopa blocks the peripheral metabolism, so it can be used inside the brain only. The Parkinson's disease questions are going to be questions about the therapeutics. What causes Parkinson's disease? Getting old. What causes Parkinson's disease? Strokes and tumors and hypoxia. What causes Parkinson's disease? Infections of the brain that damage the substantia nigra. What causes Parkinson's disease? Granulomatous disease, strokes, hypoxia, trauma, infection, anything that damages the substantia nigra in the brain. Encephalitis pugilistica. Boom, boom, boom. Too many hits in the head, breaking those neurons. Ooh, bad, bad, bad. Locked in, locked in. Just getting old happens. Ooh, crappy. Expect to see a lot of this into the future. The population is aging, and as the population is aging, there's going to be more and more Parkinson's disease. What causes it is not important in terms of the diagnostic testing or the treatment. Remember, there is no specific diagnostic test, and it's all about the treatment. Now, try to feel good about this. You may say, this is a huge pain. Why? So many things to learn. No! So many great things to offer people. So many great things to offer people. Do you know that they have analyzed what year in medicine in the history of the world is the single best year to enter medicine now, to practice medicine? You know what it turned out to be in the history of recorded time? This year! We've never been able to cure more, heal more, relieve suffering more. Never been more advanced in our therapeutics. Amazing, amazing. You're entering the amazing business. Did you know that?